So let's begin by introducing today's speaker, Dr. Matthew Lee. He received his Bachelor of Science in Biological and Physical Sciences from the University of Alberta, and then got his MD at Stanford University School of Medicine. He's a former diagnostic radiology chief resident from the Department of Radiology at Massachusetts General Hospital and Harvard Medical School. And currently, he's a musculoskeletal imaging and intervention fellow at MGH. Since the start of the COVID-19 pandemic, Dr. Lee has been involved in, of course, the care of COVID-19 patients, but he's also done research on the imaging manifestations of COVID-19, and he developed and implemented an artificial intelligence tool for improving the consistency of radiologists' interpretations of COVID-19 chest radiographs. And looking at the severity scores for those chest radiographs. And he did this as part of one of our own, Dr. Jayashree's Kilpathy Kramer's research team. And they published one of the first peer-reviewed studies in this area, applying deep learning to the analysis of COVID-19 lung disease severity on chest radiographs. Dr. Lee is one of MGB's talented radiologist scientist, and he's interested in quantitative imaging and machine intelligence, as well as his musculoskeletal imaging. And today, he's going to speak to us about radiology AI during the COVID-19 pandemic, a personal journey and lessons learned. Matt, we're delighted to have you.
Thank you so much for that very kind introduction. Let me just share my screen first. Can you see my screen? Perfect.
Yep, we're all set.
Well, thank you again, and it's my pleasure today to be talking about radiology applications of AI during the COVID-19 pandemic. Because this is a clinician AI for clinicians talk, the focus here is going to be really about the clinical deployment and the process that we went through in order to try to develop and deploy AI tools, as opposed to focusing on the nitty-gritty of the AI algorithms. But I'm happy to discuss with anyone afterwards. You can just send me an email at my email at the bottom of the screen. So I have no relevant disclosures. So over the course of this talk, my goal is to help you, the learner, appreciate the challenges and nuances regarding the clinical deployment of COVID-19 AI tools, and to also identify potentially useful applications of AI for COVID-19 medical imaging. So to help illustrate these objectives, I'm going to go back and kind of tell a story from the start of the pandemic. So in March 2020, that was when the first COVID-19 patient arrived at Mass General, or was hospitalized at Mass General. I was a third-year radiology resident at the time, and due to very high hospital census projections, plans were put in place basically to reassign volunteers, residents, and fellows from other services, non-medicine services, to the COVID floors, in addition to some faculty as well. So through that process, I actually had the opportunity and I guess the privilege in early April to spend some time basically as a medical intern again, working on a COVID floor, taking care of some of the hospitalized patients with COVID-19. So I traded my radiologist dictaphone, grabbed a stethoscope, tried to remember some of those things that I had learned in medical school, and was actually directly involved in the care of these patients, not just as a radiologist, but as a medical intern. So while I was there, I, very frequently, almost all of these patients will get a chest X-ray when they're admitted into the hospital. And typically the radiologist report would say something like multifocal patchy opacity is consistent with infection, including COVID-19 pneumonia, or some variation of that. And what was missing from this information is there is actually a lot of variability in the density and extent of lung opacities, which really, to me, seemed reasonable that could be a measure of lung disease severity. Obviously, if you have lungs with just a little bit of lung opacity, wouldn't you expect a patient who has much more severe or more lung opacity to have a worse clinical outcome? So what I noticed there is that the radiologist report wasn't really providing that information. And even if the radiologist attempted to say something like, mild opacities or moderate opacities, that wasn't necessarily something that could be consistently reproduced. So as a frontline clinician, as a person reading the radiologist report, it would be hard to use that information to help guide any kind of clinical decision-making. So what we saw there was a potential clinical need that perhaps AI could help solve. The first issue was that there was no reproducible or standardized measure of COVID-19 lung disease severity on chest x-rays that could be used for risk stratification. And second, even if we had some sort of standardized grading system, it would be difficult to scale such a system for manual rating due to issues with inter and intra-rater variability. An analogous radiology problem for any radiologists in the audience is pulmonary edema. All of us who go through radiology training can recall talking to different attending radiologists who one will say one person's mild is going to be another person's moderate, and another person's moderate is going to be another person's severe. And so the issue with reproducibility and variability among clinicians is a major problem that's hard to solve without more standardized tools like that AI could potentially help solve. So our hypothesis was that a deep learning model could be used to extract a reproducible measure of COVID-19 radiographic lung disease severity, which would be able to correlate with clinical outcomes. So how did we go about doing this? Fortuitously, before the pandemic, for about a year and a half, I had actually met Jayashri Kalpathy Kramer and had been working as a part of her lab at the Martinez Center. And so she's been my research supervisor for all of this work. And what we had been working on actually before the pandemic was developing and testing different kinds of tools to provide quantitative measures of continuous disease severity in medical imaging. And so in this paper that you can see here, published actually in March of 2020, so right before the pandemic really started to ramp up, we had published some work using Siamese neural networks in order to automate extraction of a continuous measure of disease severity. In the upper right-hand part of the screen, you can see how this measure of disease severity correlated with a manual measure of knee degenerative change in knee osteoarthritis on radiographs. And we also did this for retinal photographs and retinopathy prematurity. So we were actually quite fortuitous in that we had the algorithms almost in place, ready to go, and the experience of doing this kind of analysis to try to port this to the problem of COVID-19. So as any of you who have ever trained a model know, the data is probably the most important thing. And so then the next question is, where were we going to get the data? So unfortunately, in April 2020, which is when I was on the COVID units, that's when we really saw a peak in hospitalized patients with COVID-19 in Massachusetts. And so as a result, we had a lot of patients in our hospital, and the hospital census was, I can't remember the exact numbers, but I think something around 200 or 300 at its peak, 300 patients with COVID-19, of which a large proportion of those were ICU patients. And so we had a plethora of data. And so we were able to get an IRB related to this analysis. And at that point in time, how I ended up collecting the data is through the electronic health record, we actually had a patient list with all the patients who had tested positive with COVID. And so I'd manually collect that data and the patient information, and then go to our clinical packs and actually just manually pull each DICOM one by one. So I was able to assemble a data set of around 600 chest radiographs, frontal chest radiographs from patients with COVID-19. And so mix all that together, and we were able to actually create a Siamese neural network-based AI model for the automated assessment and tracking of COVID-19 pulmonary disease severity on chest radiographs. So to give you an idea of how fast all of this stuff was going on, I finished my time at the COVID-19 floor on April 6th, and we trained the model and tested it over the next week, and extracted data, and that includes also data extraction. And we posted our code on GitHub by April 14th, and then our preprint on May 26th, and then had a peer-reviewed publication on July 22nd. So this is all a part of that huge rush of COVID-related research that happened, that's still happening now, but was moving very quickly in the spring of 2020. So I'm not going to get into the detail of how the algorithm actually works, but please feel free to read it in the paper or to email me afterwards. But the basic gist is that we trained a neural network-based model. We pre-trained it actually on non-COVID chest x-rays from Stanford's CheckSpert publicly available data set. And then we tuned that model on a subset of frontal chest x-rays from MGH, all in patients with COVID-19, who were assigned by 3 expert annotators a manual severity score from 0 to 24 based on a system of rules. What this model allowed us to do is to create a quantitative measure, so a scale, which went from approximately around 1 to around 24 for disease severity, where the lower number would mean less density and extent of lung opacity, and the higher number would mean more severe density and extent of lung opacity. And so you might ask, that's probably not going to be specific to COVID-19, and that is true. The PXS score, as we will call it, or pulmonary X-ray score, can also be used for things like pulmonary edema or kind of multifocal pneumonias. And we were actually doing experiments related to that, because ultimately it really is a measure of lung opacity as opposed to being specific to COVID-19. But given the number of patients we were seeing with COVID-19 and the types of and the extent of their lung disease, this became an immediate use case. So what we found is that using this type of deep learning model, we could actually predict a correlation, which is the PXS score, our severity score, the PXS score, which correlated very well with the average of a number of expert annotators. And so in panel A, you can see a scatter plot that shows that correlation. And this was in our internal test set. And then in panel B, in our external test set at a separate hospital, you can see that that correlation is also maintained. In panel C on the right of the screen, you can see an example of a couple lungs with variable amounts of lung disease or lung opacities, and occlusion maps, which show the parts of the image or patches of the image that were important for the determination of the PXS score. So to give you an idea of what the PXS grading looks like, the numbers superimposed on these images are the PXS scores. And you can see with the higher numbers, such as in the bottom right-hand corner, 18.5, there's a patient with diffuse airspace opacities involving almost the entire lung with a lower lung predominance. You can see that that patient's intubated. Actually, many of these patients are intubated because these were from the early days of the pandemic. And you can see how there's a gradient or a continuous spectrum in lung disease severity as assessed by the PXS score. So what we also found is we wanted to correlate this with clinical outcomes, given that our hypothesis that worse lung disease would be associated with worse outcomes. And what we found in a cohort of MGH patients hospitalized, at least in part from March 27th to April 10th, is that the PXS score could predict subsequent intubation or death in hospitalized COVID-19 patients without endotracheal tubes on admission chest X-rays. And what we also found, what we also show is that for higher PXS scores, there was an increased odds ratio, which makes sense. We also further tested this prospectively on patients in the future from April 24th to April 29th, 2020. And what we found is that the PXS score could also help predict trial of proning as an inpatient, which for those of you who aren't clinicians, we're basically where we turn the patient on their front to help with breathing. And that simply suggests that there's an increased O2 oxygen, supplemental oxygen requirement for those patients. And it could also help predict ICU admission, intubation, and or death with the similar performance or AUROC, area under the receiver operator characteristic curve of around 0.8. So we felt like we had a kind of an interesting algorithm here, an interesting score. And a nice thing about this approach is that we weren't directly predicting the clinical outcomes. We were simply measuring lung disease severity, which is a very interpretable type of finding. So it works. So then the next question is, how do we make this useful? Sure, we have a paper, it works, great. So we work together with the folks at the MGH and Brigham and Women's Center for Clinical Data Science. And so they had a great team over there. And essentially what we had to do was develop the infrastructure and implement the infrastructure to route our DICOM images, so the DICOMs that were obtained of the chest X-rays at the time of clinical care, to not just the PACS. So typically those images will get sent to the clinical picture archiving and communication system, and then the radiologist will look at it, and the clinicians may look in the electronic health record at it. but we also needed to route a copy of the DICOM to an AI inference platform for which we use the NVIDIA Clara Deploy SDK system. This routing process is actually more complicated than it seems, and I'm not going to get into the details of it, but one particular issue that was a recurring issue and will continue to be an issue, not just for COVID, but for other AI models, is image series selection. So when you think of a radiology study, for example, a chest X-ray, the chest X-ray file or study that may often have more than one image. You can have a frontal X-ray, you could have a lateral radiograph, you can have different kinds of post-processed images. For example, here in image A is the regular frontal chest radiograph. In image B, it may be hard to appreciate, but a post-processing filter has been applied to this image to help accentuate catheters and lines. And that really just changes the nature of the actual image. You can have kind of strange cropping. There's some patients will have multiple chest X-rays due to challenging patient positioning, which is actually very common, especially in sick patients who are in the ICU. And as a result, picking which series, and so each one of these different images in the context of radiology IT has a separate series, and to pick which one that gets sent to the AI inference model is actually very challenging. And so we actually had to work very closely with the CCDS team to try to develop a rule-based systems that use the DICOM metadata to help route that the correct image. And it was, there are a lot of issues with that, and sometimes the best image may not be sent over, and so that is an ongoing problem. But at this point in time, we have the vast majority of the images that we want going over automatically. But regardless if this is for a MRIs of the brain for someone who has a stroke, or fractures of the foot, and for some fracture detection model, whatever the AI model, the series selection problem can be very challenging, and it may differ from institution to institution. So once we had figured that out, which really actually took a couple months, every chest X-ray DICOM that was obtained at MGH, at our hospital, of which there are thousands every month, gets sent to both the PACS, for which the radiologist will interpret the imaging study, but the score is also sent, or the DICOM is also sent to an AI model hosted at CCDS, and the output is then sent to a database, an SQL database, and this happens essentially in real time. And so every MGH chest X-ray performed since September 2020, so over a year now, has a PXS score assigned to it. So now that we had the PXS score coming over into a database, we're thinking of the possible use cases that we could use with this data. We have all the data. How can we make this useful for clinicians or radiologists? So our first idea that we thought about is, how can we use PXS as something like a lab value equivalent in the electronic health record? Much like how a white blood cell count can guide clinical management, you could also do some sort of clinical risk profiling by treating the PXS as kind of like a lab value. That doesn't supersede the role of the radiologist per se, because that information isn't actually communicated or extracted from the X-ray typically. But it would be kind of an interesting thing that you could trend over time, kind of like how the white blood cell count gets trended over time, and could be used to help with for risk stratification. But there were some major concerns with this. One is the issue with quality control. I just talked about the series selection issue, and we didn't have a good system for checking if the wrong image had been sent over. Obviously, if you have a lateral chest radiograph that gets sent over to the model, the AI model is not going to give you necessarily an accurate result. An additional challenge was with adding it to the health system-wide electronic health records. So we use one EHR across the health system, and as a result, adding anything to it requires a lot of different safety checks, and it can be very challenging to do. So at this point in time, we actually had to pivot, and we adjusted our use case to something like this: radiologist AI-assisted COVID-19 severity grading on chest X-rays. And the idea here is that the radiologist could provide a categorical severity score based on the PXS score, and just report that in the chest radiograph. And so in this way, the radiologist is in the loop, can assess for quality control, and because the information is coming through the radiology information system, or the PACS, it's under the purview of our radiology department. It's easier to test things and make changes than to change something that would affect the system, the entire health system. So we performed a study to justify doing this use case, where we took multiple radiologists, thoracic and emergency specialty radiologists, who at our hospital interpret the bulk of COVID-19 chest x-rays. And we had them look at around 150 chest x-rays independently without an AI system, providing a categorical score of normal or minimal, mild, moderate, or severe lung disease severity. And then after a washout period of around 1 to 2 weeks, each of them independently assessed the images again, but this time using the PXS AI decision support. And what we found was a significant improvement in the inter-rater agreement between the radiologists, which is not too surprising. I'm going from a kappa of 0.4 to 0.66. And there was an improvement for the thoracic radiologists as well, from around 0.5 to 0.75. But there was a substantial improvement among the non-thoracic subspecialty radiologists, going from 0.25 to 0.6. And so with this evidence, what we'd shown is that PXS AI decision support could help improve inter-rater agreement. So the next step was to obtain IRB approval for a prospective study so that we could actually deploy this on the clinical front. And so we were able to obtain IRB approval for a prospective observational study investigating radiologist behavior when using PXS score to assist grading. And this process was quite challenging in that obviously the IRBs were being overwhelmed with all sorts of different kinds of COVID-related clinical trials, and then the non-COVID related studies. But because we were introducing what was ostensibly somewhat of a black box technique, even though it had minimal risk, and because it was an AI model, it was something that the IRBs did not have as much experience with. And so as a result, very close collaboration with them was important in order to try to get this through. But ultimately we were able to do that. And in some ways we had to provide a much higher level of evidence than for any kind of retrospective study. So on the radiology front end, so this, again, working with the CCDS and Enterprise Medical Imaging and the team over there within the radiology department, we were able to get the PXS score delivered to the radiologist or those participating in the ongoing observational study within Primordial, which is our radiology information system. So anytime a radiologist in this study opens up a chest x-ray that was done at MGH, right along with the patient history, they will get this score, which will give you a severity score. And the idea was that the radiologist could use that information to help provide a categorical severity score based on that, which could go into the report and then help inform risk stratification. And so that observational study is still ongoing, but there are some clear challenges for the clinical adoption of this type of tool. First, adding the PXS score, it provides an additional piece of information that the radiologist needs to process and include in the radiologist's report. And that can potentially slow the radiologists down. The radiologists are already working extremely hard, and there's barely enough time to think. And so anything that could potentially slow down the radiologist or adds an additional thing that the radiologist needs to think about may struggle to find adoption. The second main challenge is education of frontline clinicians. So the main clinicians that we were targeting were the respiratory illness clinics, so some specialty clinics that had been set up related to COVID-19 and in the ER to help with triage. And the idea was that if they saw this mild, moderate, or severe from the PXS score in the report, they could use that to help guide their clinical decision making. But there are some questions about, what does that mean, especially as clinical outcomes have changed over time as more patients are vaccinated, treatments have changed, the different kinds of COVID-19 variants have come up. And so what that information means and is something that changes over time. And so new clinical outcome data is probably needed actually to keep those kinds of things updated. So there are clearly a number of significant challenges to trying to adopt this actually from a clinical perspective. So that's kind of the current state of where we are with this observational study on prospective data. The frontline clinicians are not being provided that particular aspect of the information because the point of the study is to show, to study the radiologist behavior with it. But we are also exploring other opportunities with the PXS score, such as for radiologist work list triage and tracking of change over time. And so we are trying to find an easier use case or a potentially more useful use case, but clearly, you know, we did all this work and the AI model is there and it's out there, but it's not something that's had a significant impact on any kind of patient care at this point in time. So there are a number of lessons that I think that came out of this whole journey. So before I get to that, on July 30th, so quite recently in MIT Technology Review, Will Heaven wrote this article. Hundreds of AI tools have been built to catch COVID. None of them have helped. Some have been used in hospitals despite not being properly tested, but the pandemic could help make medical AI better. And I think I agree, and largely agree with what he writes in this article. And what he talks about mainly is a couple of high-profile systematic reviews that were performed over the previous few months that looked at a lot of the AI tools that were developed and how really none of them really made a difference. And they also talk about Epic and how Epic deployed an AI tool that really didn't seem to work very well for COVID-19. And there's some question of patient safety. One of the articles that he talks about is this recent review article, systematic review on the role of AI in medical imaging. And there's really a focus on chest x-rays and CTs because that's where the bulk of AI has been applied to COVID-19. And you can see that in 2020, there were a ton of papers related to COVID-19, and a lot of them overlap with the field of artificial intelligence, and they found around 827. After going through after filtering those studies for their inclusion criteria for their systematic review, they found 463 papers. And what they found is that the most common AI COVID-19 imaging applications included diagnosis, by far the most, around 72%. Second is segmentation, usually a CT segmentation of lung abnormalities or severity assessment, kind of like what we did in our PXS score study. And three is prognostication, where researchers would do direct prognostication from the imaging studies or a combination of imaging and clinical features. So obviously, when we were working on the PXS score, we weren't working in a vacuum. There were many other groups also working on different kinds of problems. But the bulk of the work actually was related to diagnosis, and there were some substantial issues with that. And I think a lot of it comes down to this idea of statistical versus clinical significance. There are a lot of AI models that showed, at least in a test set, that you could improve, that an AI model could have very high performance for diagnosis of COVID-19 with a very high AUROC, or discriminative ability, differentiating between COVID-19 and non-COVID pneumonia or other lung disease. And the issue there becomes, let's say you have a high functioning algorithm, what are you going to do with it? And so, for example, in a hypothetical situation, which has played out in real life, if you have a chest CT algorithm that's able to differentiate between COVID-19, non-COVID-19 pneumonia, and other lung disease, and it performs really well, if the chest CT is not really used for that purpose, then that algorithm is not going to be useful. At least in the United States, where chest x-rays are really the kind of the first line clinical imaging study, and chest CTs are really done more to look for pulmonary embolism and other complications, that kind of algorithm doesn't really have any use case. On the flip side, in other parts of the world, like in parts of Europe and in China, the chest CT was actually used often as a diagnostic screening tool. And as a result, an algorithm that's able to very rapidly and accurately help diagnose COVID-19 is able to make much more of a clinical difference in that kind of environment. And so thinking about the particular clinical context and the use cases is absolutely vital to trying to make any of these algorithms work. And I think while a lot of the models have very high performance, the question now is really for the issue with the implementation gap of going from high performance models to clinically useful models is identifying that clinical context and seeing how it can fit. So the second key lesson I think that we learned is that AI model validation is only one step of the clinical implementation. The technical infrastructure for deployment, the clinical user interface, and quality control considerations are all important. And I think the serious selection problem of picking the right image to get routed to the AI model is just one example. And it's the one example I highlight, but there are other issues as well related to the technical infrastructure. And so even if you read a published paper about a really cool AI model that works really well for some sort of task, that's only the first step. And it's just the tip of the iceberg for all of the challenges and issues with deployment or implementation science. And so this is really an area in which I think there's going to be a lot of opportunity, not just for COVID, but for all of AI and radiology. And three, as I mentioned earlier, prospective AI testing is relatively new territory for many IRBs, and close collaboration and conversation is needed to help the IRBs understand these kinds of tools and also to be able to test these tools in a safe fashion, without being without it being impeded too significantly from a time perspective. So while we were trying to deploy AI models and we were working on these tools, we were also using PXS for clinical research, and we've actually found some value in just having this as a clinical research tool. So while the COVID-19 pandemic was going on, the Mass General Brigham, our overarching institution, created this task force to create this COVID-19 data mart, which would help house and provide analytics tools for researchers to study COVID-19 and do clinical research projects related to it. So we were able to get in touch with some of the folks there, including Randy Golub, and she was able to help us actually include the PXS score within that database. And so we actually have PXS scores for all of the COVID-19 patients at MGH and Brigham from around March to August. And so this is a resource that's within the MGB system, which for those who have the appropriate IRB can actually access and use this information for any kind of clinical research project that they might want to do. To give a couple examples of clinical research that we have done, in one study, we found that the severity of chest imaging as defined by the PXS score was correlated with the risk of acute neuroimaging findings, so intracranial hemorrhage, ischemic stroke in patients with COVID-19 with an odds ratio of around 1.5. So that's just kind of an example of a study in which this could have been done manually with manual rating of all of these chest x-rays by a number of radiologists, but instead we could very rapidly determine lung disease severity for a large cohort of patients and use that for a downstream analysis. In a similar type of analysis, in this study, what we found is that right ventricular strain, which is often seen in patients who have horrible respiratory disease, is actually common in intubated COVID-19 patients and is not necessarily reflective of the severity of respiratory illness. So what we showed here is that patients who have right ventricular free wall longitudinal strain could have a normal PXS score or an abnormal PXS score, and it really the severity of lung disease is not really the determining factor for RV strain. So going back to that article from Will Heaven, I think in the byline, in his last sentence, he said, but the pandemic could help make medical AI better. And I completely agree with that. I think the COVID-19 pandemic has accelerated the testing, the training, testing, understanding of the kinds of biases and common pitfalls that go into training and testing algorithms. And also a lot of lessons have been learned related to how to make algorithms useful and clinically deploy them. And so while so far, I don't think any AI tools have had a significant impact on the care of COVID-19 patients, I think COVID-19 patients in some way have really helped catapult the AI field for medical imaging forward. And I'm optimistic for the future for the kinds of tools that may hopefully be able to help patients. So thank you for your attention. I'd also just like to thank in particular Jayashri Kalpathy Kramer, my research mentor, Bruce Rosen, and the rest of the QTIM lab at MGH Martinos, many radiologists and staff at the MGH Department of Radiology, and many others who have worked on us with this type of work, including folks in the infectious disease division, the COVID MARC team, the IRB, and other researchers. So thank you so much for your attention. My email is at the bottom of this slide. If you have any other questions, I can also take them there and on this Zoom.
Fantastic, Matt. Thank you very much. That was really a tour de force here, going from really the basic science all the way through to clinical implementation. I think you highlighted a number of implementation issues that I think as people start to put not only tools that they develop themselves, but even putting tools that are maybe commercial tools into the clinical environment, these are things that need to be thought about. I also loved that you pointed out that the fact that clinical validation of a tool is something that's very different than the validation of the model itself. So we're really talking about, are you impacting inter-reader variability? Are you impacting time to care, so on and so forth, versus what the model may in fact be doing. And I also love that you highlighted, again, I say this a lot, that this is a team sport, and you need the clinical acumen to do this, as well as having the technical folks, but a lot of people had to work to make this happen. We have a question in the chat box here for you. A couple, I'll just read them for you. Could you please reiterate the clinical need that was identified early on? I know a lot of people were developing COVID models, and we know that chest X-ray wasn't really the diagnostic tool of choice for COVID. It was a viral test, but what was the clinical question? And that's a good thing. You really have to start with the right clinical question.
Yeah, that's a great question. So early on, the first thing that everyone, and when I say everyone, I mean most of the people in the clinical and AI field were focused on the problem of diagnosis of COVID-19. And I think the idea was that there are limited RT-PCR tests out there. The tests are often delayed and take sometimes the turnaround time, especially in the early days of the pandemic, would take time. And so researchers were really focused on diagnosis of COVID-19. And our group from the beginning, we weren't particularly optimistic about that use case, just because of the non-specificity of the COVID-19 lung imaging findings, and that's a whole other can of worms. But so what we ended up focusing on is really how do we better extract information from the chest X-ray to risk stratify patients for prognosis. And so the idea was that there are a lot of patients who show up at the hospital. Some needs to be intubated, some needs to go to the ICU, and there are limited ventilators, there's limited ICU staff. And especially in that first wave in Massachusetts, where we had a lot of patients in the hospital and limited capacity, we wanted to be able to help give information that could help the frontline clinician potentially discharge a lower risk patient and then potentially admit or have closer monitoring of a higher risk patient. And so it was really, the original goal was for the purpose of risk stratification. And so our thought was that kind of risk stratification would be helpful for the frontline clinician. But the problem with directly predicting clinical outcomes is that, and this is something we thought about from the very beginning, is that if you directly predict it, there are a lot of biases and additional information in the chest X-ray that might be affected, like things like subcutaneous fat. Like if there's a lot of obesity as evident in the image, that is a known risk factor for more severe COVID outcomes. And so we wanted to have something that would be more interpretable, which, lung disease severity, if you look at the chest X-ray, you can see it. We just wanted to be very consistent and provide a consistent score for lung disease severity. So something that's more interpretable and also potentially more reproducible over time. I think that actually has a segue into another question that I see in the chat box from Dr. Previdello on has there been any evaluation of whether the model maintained its initial performance over the months as different population groups were being affected by the pandemic? And I will say, from a lung disease severity standpoint, the model performance has been maintained, and we've tested it in further populations. So the correlation between the PXS score and manual annotation of lung disease severity, at least for a few months after the model was initially developed, we continued to look at that and just see, does that make sense? Admittedly, in 2021, we haven't. So with the Delta variant, we haven't really looked at that. But for most of 2020, we were looking for that, which actually makes a lot of sense because, just from being a diagnostic radiologist, the lung manifestations haven't really, the actual, peripheral ground glass or consolidative opacities, kind of with a lower lung predominance, those things have not changed a whole lot. In terms of actual prediction of clinical outcomes, we have not done an updated analysis of that, but I fully expect that will be completely different now, as given that a lot of the population is vaccinated. The patient demographics have significantly changed as well among those who are getting COVID. In the early days, it was really a lot of older patients, and also, unfortunately, a lot of patients from underrepresented or minority communities in particular, especially in Massachusetts. Whereas now you have a lot of younger patients, patients who with different demographics. And so that's something that I think any kind of prognostication type model that's directly trained for prognostication is going to really struggle with. And that's why we focused on lung disease severity as our initial clinical question, is something that could be reproducibly assessed.
Fantastic. And, I did have a question, maybe you can clarify for me, I just might have missed it. So I thought you mentioned initially the annotations had been done on a 0 to 24 score, severity score, yet when you tested for the radiologists and what they were reporting, what was being reported in the report, and then subsequently as you're studying the impact of that score on their reporting, you went to sort of normal, mild, moderate, severe kind of thing. How did you come up with the 0 to 24 and then break that down into the?
Yeah, that's also a good question. So the original scoring system is based off a scoring system developed for ARDS. So basically patients with respiratory disease, which was originally called RALE, or RALE, radiographic assessment of lung edema. And so this was a paper that was not, this was a scoring system that was not developed for COVID-19, but for ARDS. And that scoring system was actually a 48-point score in which the lung is divided into, or both lungs are divided into 4 quadrants. And then each quadrant gets a density and extent score. So a density of consolidation and extent of lung disease in that quadrant. And so, early on in the pandemic, we were just trying to find, what could be a relatively reproducible ground truth. So we took that scoring system and we just treated each lung as a single lung. And so we had the score. So it ended up being 24. The issue with this kind of manual scoring is that, and we found this from having multiple annotators, we've had 5, 6, actually we probably have 10 different people doing annotations at one point or another now, all radiologists. And there's a lot of variability between the radiologists in trying to provide these assessments, just because unlike a chest CT where, on a chest CT, you could draw you could manually segment where the lung opacities are, like where ground glass opacities or the consolidation, because often there is a relatively clear demarcation between abnormal and normal lung. And of course, in some cases, that's not the case, but often there is. Whereas in the chest X-ray, it's almost never the case. And so that manual grading was actually very challenging. And so to provide information to the frontline clinicians, it actually didn't quite make, it would be hard for a radiologist to just, or to just try to produce that score on the fly. And that would be much more time consuming. And so what we did is, functionally, we can just have these 4 ordinal categories: normal, minimal, mild, moderate, and severe. And using those categories, we found that, as you go to higher categories, there's a greater odds ratio for poor outcomes, so intubation or death. So they're still functionally important. So the idea was, if the radiologist says this is mild, this is going to be a low risk patient who we can maybe at least feel more comfortable in the context of the entire clinical picture to discharge this patient to home, as opposed to a patient who maybe clinically actually looks okay, but they actually have severe lung disease on the radiograph. And then that might be a patient, oh, maybe we should actually observe this patient or send them with home oxygen or something like that. And so that was kind of the rationale to do that. And these manual scoring systems, especially as the more granular they become, the harder it is to make them reproducible. And so for at least for that purpose, that makes sense. From the perspective of trying to use PXS score as like a lab value, it does make sense to just leave it as the numeric value. But for radiology assisted scoring, it just made more sense to try to do a less granular grading system.
And I thought it was very, very interesting that you pointed out something that we've looked at in terms of clinical decision support. Does the clinical decision support help maybe the more junior or the non-specialty clinician or non-specialty radiologist? And seems that you had more of an impact on the ED non-thoracic radiologists using this score, which is fantastic. Maybe we can spread high quality care to areas that don't have specialty care. We have a follow-up question here. Have there been attempts to compare scores with attenuation-based scores on chest CT lung segmentations that are used for emphysema? Have you looked at that at all or thought about that?
We have thought about that. We do have a data set of chest X-rays and chest CTs, and we did also train our group. I shouldn't say I did, but others in our group trained the segmentation models related to lung opacities. If you can segment the lung opacity, then you can also extract the Hounsfield units from the areas of lung opacity. And so it's something that we could do. We haven't used the types of tools used for emphysema in particular. But that's definitely an interesting idea, and it's something that would certainly be interesting to try.
One thing I wanted to mention, and you really talked about this and lived it. Well, a couple of things. One is the astounding speed with which you were able to, kind of the perfect storm of having a model in the bank, having a data set from the Stanford Chexpert data set to use for variety and heterogeneity and normals. And then getting it published, mere months later was really quite fantastic. And I think that just speaks to the need for having data repositories that are available for researchers who may not have access to data even as much as you do at our institution. Just a mention of the MIDRIC data set that is a collaboration. Jayashree, Dr. Kopathi Kramer's involved in that, folks from the RSNA, the ACR, and the AAPM, and Mary Ellen Geiger at University of Chicago is manning that data set. And it started with COVID cases, and they're annotating data sets and so on. And hopefully that will be a model going forward for people to get things up so quickly. But I thought that was fantastic. And then another comment that I thought was interesting, you touched on the IRB issues, and people may not be aware, but if you are touching an image in the process, that tool is considered a medical device. So software as a medical device. Yeah. And so in terms of the FDA, so you have to think about that. And of course you are touching a medical image. And even though you were using it as clinical decision support, that makes it a little bit softer, but interesting. And I think this was for our institution a use case for the IRB learning how to deal with these issues, and Dr. Kopathi Kramer knows this in spades as to how to get this going forward. And there are some issues that we have to think about, and it's not always that the patient is the subject either. In your case, the radiologists were the subject, yeah. But in terms of getting the IRB approved for AI trials, some of these things have to be thought about. And one last comment that I'd like to make, if people are not aware, last year there was a demonstration that was virtual. Unfortunately, we're repeating it with some enhancements this year at the RSNA, which will still so far is going to be in person until further notice. But it's called the IAIP, the Imaging AI in Practice Showcase Demonstration. And what this was we used a couple of clinical scenarios of an acute finding and a chronic finding. So suspicion of stroke, do the CT, do the MR, and so on, find incidental thyroid and lung nodules in the care of the patient, and follow that through really the workflow and the imaging chain for this patient's care vis-a-vis imaging, using integration data standards, AI tools at the different points in that, and then using these integration standards, such as some of the DICOM that have been extended for AI, and the IHE profiles, reporting standards and templates, and so on. So if people are interested in this gets at what Matt's study has really done in reality, in going from a model to now implementing something in the clinical arena, and some of the things you have to think about, and some of the tools such as the orchestrator, which decides, what is the series that is necessary for this model to consume. If you're looking at stroke on MR DWI, and the MR that you're looking at doesn't have that sequence, then your model's going to be in trouble, and so on. But what are your plans to look more at the quality assurance and the perhaps creeping of the model over time? Have you thought about some studies or some mitigation methods for that?
Yeah, that's a great question. It's definitely something we've continued to think about. I think one thing that Jayshree and I are particularly interested in, and many others as well, is related to the out of distribution detection, where when you train models or AI deep learning type models to identify images that may be out of the distribution of the training or test data. And I think there was a good paper, I think, by a group, I think, out of Stanford and Montreal that just came out recently, just talking about reviewing these out of distribution detectors. And so I think that's one aspect. In terms of things like clinical correlation, keeping track, or monitoring of clinical outcomes, that becomes more challenging, because then you have to integrate not just the imaging data, but also clinical data, which means you're interfacing within a whole other IT infrastructure, which in most places is separate, like the radiology and the electronic health record IT infrastructure. But at our own institution here, Oleg Pionk does a lot of work with continuous learning and the idea of updating the models. But then you have to deal with the issue of catastrophic forgetting, where the model on an update basically loses its predictive value or predictive power. And so it's a very challenging problem, I think. But that also means there's a lot of opportunity. And I think for me and for everyone else who's interested in this topic, there's a lot of work to do.
Well, I'm glad to hear you say that, because my last question, if I have no further questions from the chat box here, is, you were in training when I know you had some previous training at Stanford in AI and machine learning, but you were in training as a diagnostic radiologist when this was all coming on scene. Did that concern you at all, that maybe you had chosen the wrong specialty? And what are your thoughts now that you've sort of rolled up the sleeves and been elbow deep in this technology?
Yeah, it's also a good question. I would say that back in 2014, one of my friends told me, you should learn about deep learning. And I wish I had taken up his advice on that in 2014. But when I started radiology, I'd done a lot of bioinformatics work, but not so using large multi-dimensional data sets, but nothing with deep learning architectures. And I would say that in the beginning, I was a little scared about the future of radiology. But at this point in time, I feel like there's only opportunity. And the more AI model training I do and testing and trying to deploy things, the more problems I see, and also more opportunities I see. And so I think for anyone who's interested in pursuing a career in radiology, it's still a really good option.
Yeah, that's an excellent message. And I'm afraid we're up with time. I want to be respectful of Dr. Lee's time, and he needs to get back to his clinical work. But I want to thank you again for a wonderful talk, and really a tour de force from the model development all the way through to clinical implementation, and the things you have to think about, the little things you have to think about to make a true clinical implementation and impact. So thank you very much. And next month, the 14th of October, we will have Dr. Ron Summers. So thank you all for joining. Thanks again, Matt. Thanks to Karen.
Thank you, Dr. Andrew.